Hello and welcome to Pulse and Progress. This is a podcast that seeks to focus on real stories as we attempt to unravel or explore some bold solutions to some of the challenges that we're all facing as a globe, so to speak. So, in this episode today, which is the first of a series of 6 episodes, we will be focusing on rethinking global health, protecting progress amidst uncertainty. And to give us some context, the global health landscape, especially in recent years, has been marked by increased fragmentation, unilateral decision making, and abrupt cuts to financing critical health programs. And the need to amplify voices of reason, leadership, and evidence backed expertise is becoming increasingly urgent. And that forms the basis of our first conversation today. And I'd like to now introduce my guest, Dr. Sam Oti, Senior Program Specialist at the International Development Research Center, IDRC. Thank you so much for making time to join us.
Thank you for having me.
Thank you. And Dr. Chris Barasa, General Secretary and CEO at the Christian Health Association of Kenya. And I'm Terry-Ann Chebet. I'll be the host for this podcast. Part of me wants to say Dr. Chebet, but not yet, coming soon.
Yeah.
All right, let's just go right into it. And given the context that we gave in the beginning, following the withdrawal of donor funds by countries such as the UK, the United States as well, what would you say is the current state of health funding across Africa? Let's start with you, Dr. Oti.
Yeah, thank you, Terry-Ann. Really a privilege to be on this podcast. I think before we go into the state of healthcare in Africa, let's talk about the bigger picture. How did we even get to where we are today? And there's this story that I heard. I don't know if it's true, but I always repeat it because I think it's very illustrative of the state of healthcare in the developing world. So it is said that there's this group of public health experts from the West. They visited a country in Africa. They went to a village. They gathered around the village leaders. And they said, you know what? We heard that there's a problem of malaria in this community. And we would like to help solve that problem. And the community leaders were like, okay, this is excellent. We really appreciate you coming. But here's the thing. At night when we sleep, rats, they come and nibble on the fingers of our children. And that's a nuisance, and it's really annoying. So here's the deal. If you can help us solve our rat problem, we will help you solve your malaria problem. And that framing was I think is very interesting. Now, I don't know if the experts went ahead to solve both the malaria and the rat problem. I think most likely they concentrated on what brought them there. But I think this story just illustrates the state of healthcare in Africa. That here you have a group of vulnerable people. They have their health problems, right? But their governments clearly are not solving those problems. So it's taking people from outside their country to come and try to help solve that problem. But now these people are coming with their own agenda. They have a very specific agenda. And it's fine. It's fine. Malaria is probably a problem. And if they solve it, that would be great for that community. But it doesn't solve the rat problem. And I think that is the state of healthcare. I think that is very illustrative. And I think the backdrop of that, or the takeaway from that, is that our governments across Africa are not investing sufficiently in healthcare. I think it was in 2001, all African leaders got together and committed to the Abuja Declaration, where they said they're going to put aside 15% of their annual budgets to healthcare. Till date, I think it's only 3 countries, Botswana, Rwanda, and I think Cape Verde, that have consistently reached that target. The others have not. But where are they putting that money? Instead, they're putting money in defense. Defense has a much higher allocation for most countries in Africa than healthcare. Why is that? Many countries in Africa are not fighting wars. They are not dealing with these insurgencies. Nobody wants to fight you anyways. So why are you spending all your money in defense? And there are people who are dying from preventable diseases. And so against that backdrop, having these funding cuts is really devastating because we have a chronically underfunded healthcare system. Healthcare systems across Africa. And now with USAID and US government funding going away, it's even worse. I think on average, the US government was giving around $10 billion through USAID to development. Not all of it went to health, but a significant proportion went to health. And to put that in context, $10 billion is the GDP of Togo, the entire GDP of Togo, and the entire GDP of Malawi. And now almost 80 to 90% of that is disappearing. So you can imagine the massive gap and the state of jeopardy that our healthcare systems is currently in.
Thank you so much, Dr. Sam, for that illustration, which clearly shows, from a budgetary perspective, as African nations, we're not allocating enough consistently, and of course, an over-reliance on external funding. Dr. Barasa, what are your thoughts about where we currently stand?
Okay. Thanks, Derian, for inviting us for this podcast. I feel privileged to continue actually advocating, because that's my work as a CEO at the Christian Health Association of Kenya. One of the things that I do on a daily basis is to advocate for more and better funding towards health. Because why we do that is because we come from a background of serving the underserved populations in this country, because 40% of Kenyans actually are served by the Christian Health Association facilities across the whole country. And you realize that most of them come from very remote and underserved parts of this country. So when we've had a funding cut, I don't want to go back to what my colleague Dr. Oti mentioned, but if you go back to what happened during early this year when we had a stop work order by the current US regime, actually the poorest of the poor were hit hardest for that matter. And why that's the case is because they rely a lot on donor funding. And this has been the case for a while now in our countries. Even before devolution, we had global health programs, what they call the North-South global health support. And I have a different opinion in terms of the funding models based on the interests, because we usually say in global health that we get funding so that we can contain infectious illnesses at the source. That's what global health is all about. We usually say it's not that the North really wants to help Africans for that matter, but it's a fact that they want to contain infectious diseases at source. And that's why you realize that at some good extent, because of global health security, okay, when you have malaria, when you have HIV in Africa and it spreads to the US, because we are mobile, you cannot detect that I have malaria when I'm at the airport, at Jomo Kenyatta International Airport. But I could be carrying a parasite to the US for that matter. So we need to look for ways of containing that. But there are many benefits that have come from that, as much as that could be the case, because African countries largely have benefited from this, building health systems over and over. So when the global funding from the USG, from the UK came to a standstill, actually we've seen a lot of impact. I work with the communities a lot, and one of the things that has been affected the most is actually in relation to HIV, TB, the immunization programs, and also other non-communicable diseases like cancer control. Because these are programs that are largely funded by donors. So you can imagine some county governments, despite the fact that health is devolved, have very minimal funding or budget allocation towards HIV. So when actually this happened, most of our patients went without essential commodities. Most of our patients went without access to essential services that they needed to have. And we noted, especially within our programs, we noted a spike in the number of what we call complications arising from patients on treatment for HIV, for TB. We noted a significant reduction in the number of patients accessing healthcare, because some of these programs actually support them to an extent of even allowing them to have that access. We noted a significant reduction in the quality of care because over 10,000 healthcare workers in this country are supported by donor funding. You go to some of the counties, you realize that 60%, 70% of healthcare workers are actually supported by the global funded projects. So what that meant basically is that you go to a facility and there are no nurses. You go to a facility and there are no clinical officers. There are no actually no even what the people, community health promoters who are able to support these people. I am a gynecologist. Let me end by saying that the most hit person was a mother and a pregnant mother with their child. Yeah, they were the most hit person because the immunization programs are running on this. Luckily, as a country, I think we've been able to manage some of this. Like the immunization program now is being supported to a good extent by the government. But mothers who are pregnant, who are accessing maternal child health interventions through this support, they've been hard hit. And Terry, I want to assure you that you are yet to see the impact of this. In the next 1 year, in the next 2 years, that's when you shall start seeing the impact of this funding cut. Right now, not yet, because some of these things take a bit of time before they start manifesting. So unless we do something significant in terms of managing this, then some of the outcomes may be terrible in terms of just reversing some of the gains that we've made as a country towards achieving universal health coverage.
And you have mentioned something that I would like us to circle back to a bit later in the conversation on funding models and challenging the current funding model. So I'm curious to hear both your thoughts on what that should look like. I'll come to you, Dr. Sam, now. Just still staying on the topic of funding cuts. From a community perspective, how are communities being impacted? And Dr. Barasa has touched on a pregnant mother, for instance, and you've mentioned TB and immunization. Can you share perhaps some either real-life examples, either from a lived experience or some stories that you may have heard?
Yes, no, absolutely. And I'll talk about it from maybe 3 levels. So at the very local level, there's actually statistics to back what Dr. Barasa talked about. A study by Jacaranda Health. They interviewed around 5,000 mothers across Kenya. And about 40% of them reported that the wait times at clinics has increased because these clinics are now understaffed because of the cut in funding. They interviewed health workers, around 500 health workers, and around 60% of them said they are noticing that there's stockouts of medicines that should be available, again, as a direct result of these funding cuts. And then, anecdotally, I read a story of a young lady, 19-year-old in South Africa, living with HIV, who said prior to the funding cuts, they used to deliver their ARVs to the doorstep. But now she has to travel 1 hour just to get them. So yes, it's an anecdote, but that I think is illustrative. But even at a global level, there are large and important agencies that have been affected by this cut. WHO, Gavi, which is the Vaccine Alliance, UNICEF, and we might not really understand the impact of the cuts, except we understand what those organizations actually do. And I'll give an example with Gavi, for example, which is the Vaccine Alliance, and they make vaccines accessible to low-income countries. For example, we are all excited about a new malaria vaccine that has been discovered not long ago. And there were plans to make that vaccine accessible to low-income countries. But now Gavi is facing a shortage of $3 billion. How that is definitely going to have an impact on their ability to provide those vaccines to those who need it. And remember, malaria is a horrible condition. 600,000 people die annually, and mostly children, and mostly in Africa. And that's just one condition and one vaccine. So imagine all the other vaccines that they are responsible for. WHO is also impacted as well. So this is really devastating, and there's a state of confusion among a lot of these organizations. But I think that there is some hope, as Dr. Barasa said, that some of our governments are beginning to respond and beginning to take some of the right actions, which you can talk about later on.
Oh, wow. I just, as you say that, and I know you said there's hope, but I'm just thinking, is there? And I'm also curious, why is it, you mentioned that only 3 African countries have met the threshold of the Abuja Declaration. Why is it so hard for African governments to, commit more to budgets, to bigger budgets in the health space?
Yeah, and thanks, Rian, for that. I look at it from 2 perspectives. One is that we are used to being funded. Yeah. So winning ourselves off that becomes a bit of a challenge. And it's like when you have a small child and you've been giving them certain kinds of foodstuffs, they won't think about other sorts of foods. So as African countries for a while now, we've been funded. And you will be surprised, Terry, that some African countries or some county governments now, as we speak in Kenya, as I said earlier, they don't even consider HIV as one of their priorities because they know that there's a donor who will come in and give them the money. So we deliberately stop putting those in the budgets. I've participated in many annual work planning processes in this country. And what really surprises me is, Terry Ann, when it comes to HIV funding, when TB funding, we just indicate they are donor funded, donor supported. So it's deliberate because we know someone else will plug in. The second thing is probably, and I get pained when I talk about this because how much value do you attach to human life as African countries? Does it matter when you hear that 2 women died yesterday because of preventable cause? Trust you me, a woman dying, I was in Belgium at some point, a maternal mortality will actually lead to the highest person in the office, in the Ministry of Health, resigning. It's unheard of. Yeah. In this country here, we lose over 6,000 mothers every year, and life goes on. So until such a time when, as countries, as African countries, will attach value to human life and have that converted into what are we benefiting from saving this life, people will not see from that perspective. So as long as we remain in this space where we don't see the value of saving lives, and especially mothers and children, then we won't see value in even funding health for that matter. Because a mother dies and life goes on. Okay? Out there, a mother dies, a minister resigns for that matter. So how do we move from that aspect of not valuing life to a space where we value life and we actually budget and work towards ensuring that we protect and save our people from dying? Yeah.
Within the context of funding models, and if we can now just look at some of the responses that we're seeing from African states, or the responses we will be seeing when some of these programs run out, how do you see them positioning themselves within the current state that we're seeing? And if you could just tie that in with funding models that could work.
Yeah, absolutely. I think for now, there's still a lot of confusion. Let me put it that way. I read a blog by the CEO of CHAI, the Clinton Health Access Initiative. And so they are working with ministries of health and with governments to really understand, because like Chris said, some governments don't even really understand the full extent of what they've lost now that this funding is gone. So CHAI is helping them to try to understand what the scale of the losses are. But what they are finding already, in addition to the confusion, is that there is some positive signs. For example, in Burkina Faso, the government is finding efficiencies in terms of reallocating resources. So, for example, they were going to spend about $7 million in Burkina Faso on workshops. Now, workshops are important. I'm not trying to diss them in any way. They're very important. Opportunity to network, opportunity for capacity building, etc. But they made the call. They were like, this is not something we need at this point in time. So let's reallocate that to maternal health, and that was what they did. In Nigeria, immediately the cuts were announced, the parliament, or what they call the National Assembly, decided to allocate $200 million to the national budget to cover for the funding cuts. But to me, these are all, I'll call them band-aids. They are not addressing the fundamental issue, which is a chronic underinvestment in healthcare. Now, is that going to change anytime soon? Hopefully, we'll see some changes, and we're beginning to see some changes. But I think there is an opportunity for innovative financing mechanisms. There are ideas like blended financing, and there are ideas like social impact bonds. And I'll give a very good example with blended financing. So the organization that I work for a Canadian funding agency. So we fund research and innovation in the Global South that is led by researchers and innovators in the Global South. And one of the projects that we are funding is looking at how we can support primary healthcare centers across Kenya, those that are run by private providers. Really, you think of them as mom and pop shops, primary healthcare providers who don't have access to a stable and reliable electricity. So in the rural areas, in the remote areas, and they cannot afford to install, let's say, solar panels, right? Because it's just too capital intensive. So what we're doing in that case through this blended financing project is that you have a third party, like a private entity, where they call them solar as a service provider. Now, they have the equipment and they have some resources, and they're going to purchase this solar equipment and supply it to these primary healthcare centers, but not to buy. It will be like a lease. So they're going to lease it out to them, and then they pay a small monthly subscription fee to have electricity from those solar panels. And then they'll be maintaining it. And if there's any troubleshooting that needs to be done, this solar as a service companies will support these primary healthcare providers. But where does the blended financing come in? Now, local banks ordinarily would not put their money in this solar as a service. They will not give them loans because they need to purchase this equipment, and these equipment, they need to import them. Ordinarily, they will not give them loans because it's too risky. So this is where blended finance comes in. It's almost like an insurance. So a development partner, let's say like the Gates Foundation or some other development agency would say, okay, you give loans to this solar as a service companies. You give them loans. And if they default on the loans, we will compensate you for that default up until a certain limit. And so that incentivized the local financial institutions to now give out credit, give out loans to these solar as a service providers, and then they can now service this primary healthcare facility. So that is blended financing. It's bringing development finance, mixing it with private finance, and then you have this potential impact on electrification of primary healthcare facilities.
Okay. Dr. Barasa, still staying with how African countries are mitigating the impact so far, and as we have said, we have not yet really felt the true impact of it. From a solution perspective, and when it comes to some innovative funding models like blended finance, are we likely to see some locally led solutions, especially now that you said you're focusing on mashinani?
Yes, I'm optimistic. I'm optimistic that we are likely to see locally led solutions. And let me give you an example of our country, Kenya. For the very first time since the Alma Ata Declaration in 1978, Kenya has funded primary healthcare. For the very first time. We've never heard about that. We've never seen that. But now they have invested and supporting primary healthcare from the exchequer, not from donor.
For the first time.
For the first time. That we have a budget line and is supporting primary healthcare. So to me, those are some of the signs or some of the indicators that tell me that countries, and if countries like Kenya can be able to put aside some money towards supporting certain interventions. The second thing why I say there is hope. Usually, I'm a firm believer of, in any calamity, there's always a window of opportunity. So as a country, when the stop work order happened instantly, we have to think. Yeah. And I think there are a number of opportunities that we need to now think through. And one of them definitely is, could there be other donors, whether individual donors, whether other entities, business models that my colleague Dr. Oti has talked about, that could now be embraced? Because we are used to getting grants, but are there other business models that can still deliver on healthcare? And I like what he's talked about, the blended financing aspect, because even as Chuck, it's something that we are embracing. Over the 600 facilities that we have, we've been looking out for innovative ways. And just last week, I was in one of the hospitals and I asked the CEO, how much money do you spend on water? And he told me about 500,000 per month. Then I asked him, so if I got you an innovative way of harvesting water, because I see you have a whole surface area of roof and all this rainwater is just going to waste. What if we came up with an innovative way of harvesting this rainwater? And then I had an innovator who came actually with me, and he said, we can be able to save this facility 200,000 every month through a particular model that we can be able to put here. And in the next 15 years, they would have paid back for this innovation. Then everything now goes to zero. So for the next 15 years, moving on, it will be zero. Then the second person came and told me, Kenya is usually sunny most of the year. We can be able to have solar panels in your facilities. They said, sounds attractive. So he asked me to look for what's the cost of electricity in our facilities. And we've done that, picked that information. So the question is, can we be able to put solar panels for you? Because I have some seed capital as an investment. But then whatever you usually use to pay electricity every month, you'll be paying back for the next 15 years. After the 15 years, we will give you another 15 years of servicing and replacement. After 30 years, maybe by that time, when solar panels will be absolute. We may have some other technology of managing this. So what that means is that the facilities can be able to plan moving on for the next 30 years with a more reliable funding model. And they're not going outside what they usually consume. It's just what they consume, but being used in a different way. So what am I saying, Terry? That we must, even as a country or as countries in Africa, look for more innovative ways of funding our healthcare. Because someone has to pay for it. Okay? And that someone is you and I. The last thing I wanted to just mention is even the drive towards achieving universal health coverage as a country. I know now there's a lot of noise. Okay? A lot of noise because things don't seem to be working. I posit that probably we have very good, and I've mentioned this to the highest offices, we have very good thoughts around how to fund our health sector. But one of the challenges we usually have is implementing those models. So we must think through what are some of the governance systems that we must put in place when implementing some of these financing models, because we are working, for instance, in Kenya in a devolved state. Okay, how does national government and county government work together to be able to implement some of these funding models that we have? Because we cannot rely always on the exchequer, we cannot rely always on the national government, but facilities, county governments, local communities must come up with models that are responsive to their needs at that local micro segment. We may get better solutions than relying on global funding that will be more or less like they're giving you fish to eat. Instead, they'll be giving you
A fishing rod.
fishing rod
Fishing
for
rod.
you to go and actually fish. Yeah.
And that leads us to the next part of our conversation on leadership, which you have both alluded to, and the role that either both a strong and a visionary political leadership would have in plugging the funding gaps that we're currently seeing. What do you see as the role of government? Let's start with you.
Well, the role of government is crucial. It's absolutely crucial. And just, I think it was about 2 weeks ago, former heads of state convened by the president of Ghana met in Accra. They called it the Africa Health Sovereignty Summit. And there was former President Obasanjo of Nigeria, Ellen Johnson Sirleaf of Liberia, and the Director General, Dr. Tedros of WHO. And they, at the end of that summit, they came up with a communique. And the communique had a number of points that I think are pertinent to your question. First of all, they said they want what they call a new global health order.
Yep.
And what they mean is that they want a situation where countries in the global south, low and middle income countries like Kenya, really have a seat at the table.
Yeah.
When decisions are being made. That we don't want a situation where decisions are made over there and then we are forced to fall in line. They want us to have a proper seat at the table. Another thing they talked about is that they want, again, exactly what you were talking about, Chris, diversified and sustainable sources of funding and financing for healthcare. So they are looking at domestic resource mobilization. They are looking at the private sector. And so they are calling for African leaders to prioritize domestic resource mobilization for health. Another thing that they talked about is that there's also a framing. So generally, we tend to see healthcare as a sector that consumes.
Yeah, that's true.
That is the mindset that we have, is a sector that consumes. Whereas, so what they were calling for is that we should reframe healthcare as a sector that is a driver, a catalyst of innovation and productivity. And if you have that mindset, the way you invest in healthcare is different from the way you treat it. If you treat it as like a drainage pipe where money is just being lost. But the last point they made, and I think is absolutely critical, and I think is the elephant in the room, they were calling for national accountability. There was a study I saw that estimates that between 20% to 40% of the funding that comes to the healthcare sector is lost through corruption and lack of transparency. 20 to 40%. So on one hand, we are not even investing enough in the healthcare sector. Most countries in Africa are not getting to the 15% target, right, of annual budgets. And then even that, 4 to 5 to 6% that they're contributing, you're losing almost a third to a quarter of it to corruption. That is just not sustainable. And I think that is where we need good leadership. That is where we need also people to hold their leaders accountable. Otherwise, what's the point? What's the point of putting more money in the healthcare sector if you're still going to lose 20 to 30, maybe even 40% of it to corruption?
Yeah.
Dr. Barasa, your thoughts on the same?
Yeah, governments play a very critical role in terms of as a facilitator, an enabler for both the private and public provision of healthcare. And I'll give you an example of our country, Kenya. Just about 52% of people in this country access healthcare from the private sector. So how is the government facilitating the private sector players to deliver healthcare? It's a very critical question, Tirian. And when we have, let's say, acts of parliament that should be facilitative, my take is that governments should be able to have a facilitative role to enable the private sector to deliver on their mandates. Because governments cannot be a regulator and a service delivery provider at the same time. And it never works in any order. Yeah. So governments play the role of regulation, play the role of policy, But you'll find that a majority of the population in the African setup, actually, they will more likely get access to healthcare from the private sector. So how can government facilitate the private sector to provide more of these services? Okay. If I was to import a CT scan machine from Germany, for instance, how much tax will I have to pay? Significant. So how do government facilitate such that some of these global north entities can do business from a health space in a better way? The second thing I wanted to mention, and Dr. Ote has alluded to it to some good extent, is the issue of pilferage. Okay, so governments have a role to just ensure that, to facilitate a scenario where the funds that we've gotten either from global north or locally are actually utilized to improve the quality of services that we have. I know there are many mechanisms that some governments have done. And I'll give you an example of Rwanda. Rwanda is a country where I think the government has been very deliberate. I was there for a conference at some point last year. And when I was watching news, actually, one of the senior state departments, or rather in the Ministry of Health, had to resign. Okay, again, because there was a mass traffic accident. That was in the Ministry of Roads. There was a mass traffic accident that would have been prevented. So the point was, where were you when this was happening? That road should have been repaired. But there was some money that was given and it wasn't utilized as appropriate. And so then I had that thought, can that happen in Kenya? So how can governments, and the point was that such kind of information reaches the presidency and you better exit because they'll exit you anyway. And it's clear that if such things happen, then there are repercussions. I think in our country and in most other African countries, we are lacking that kind of deliberate action towards minimizing and reducing pilferage. And I think if we do that, we may just get better funding models, better utilization of resources, and we'll be more accountable both from the end user and the provider perspective. Yeah.
All right. Dr. Ote, I'll come to you now with a focus on African multilateral institutions and the role that they would play or they could play in the meantime. And, I listened to African heads of state shouting from the rooftops about we want trade, not aid. Yet in the healthcare space, they, want aid.
They call for aid, yes.
So what role can the African multilateral institutions, to be specific, play in that space?
No, they'll play a very important role. And I think about an agency like the Africa CDC potentially, and what they're trying to do for vaccines, for the vaccine ecosystem in Africa.
Yeah.
So we learned the hard way from COVID that Africa only produces 1% of the vaccines that we use in this continent. 1%. It's shameful. 1% for a continent of 1 billion people. We only produce 1% of the vaccines. And so when COVID came, we had to beg. We basically had to beg and wait in line and to see if we would get any vaccines. And so that situation is not sustainable. And so what Africa CDC is trying to do is to create the regulatory environment to enable Africa to scale its vaccine manufacturing capacity. So they have a target of 60% scale. We should be able to produce at least 60% of the vaccines we use by 2040. And part of their efforts includes setting up the Africa Medicines Agency. And what that agency is going to do is going to streamline regulation. So if you're a pharmaceutical company that wants to come into Africa, rather than having to deal with, 50 plus different regulatory agencies, you just go through that one Africa-wide agency. And when you get the approval for that product, you can now access the 1+ billion people that we have in the continent. So they are trying to streamline regulatory processes. They are also trying to just make those processes easier. And I'll give another example of what Africa CDC in collaboration with WHO are trying to do. For example, we had this outbreak of Ebola in Uganda. It's the Sudan strain of the Ebola virus. So it's the one that doesn't have, currently there's no vaccine for it. Now, when the outbreak happened, it was, I think, September 2022. It took WHO and the Ministry of Health in Uganda and local partners, it took them about 3 months to set up a clinical trial because they are candidate vaccines, but none has been approved. So what you do during an outbreak is that if there are vaccines that have passed through certain phases and are deemed to be safe, you can test them during an outbreak to see if they work, right? But by the time they could set it up, somehow the Ministry of Health in Uganda got the Ebola outbreak under control. Now, fast forward to 2025, there was another outbreak. But between 2022 and 2025, WHO had been working with the regulatory agencies in Uganda to get pre-approved clinical trial protocols so that if there's an outbreak, they can act right away. And so when the outbreak came back in January 2025, it took them only 3 days. It was record-breaking for them to be able to set up the clinical trial. And that clinical trial is ongoing. And hopefully by the end of the year, we'll have a vaccine for that strain of Ebola virus. So I think these agencies have, especially in creating that enabling environment, sort of streamlining regulatory processes, I think these multilateral agencies are absolutely critical.
All right. So we're almost coming to the end of our conversation, and I'd like us to look at a more positive or or some
there are a lot of positives, yes,
and some solutions that that we can look at. So the first question I'd like to ask both of you is, what must stakeholders urgently prioritize to safeguard the progress in health so far? And you have both talked about some of the African countries, Rwanda, for instance, Kenya, and we might be 30, 40 years late
but
on primary healthcare. But there is some hope. So what must stakeholders urgently prioritize? Let's start with you.
Yeah, that's an interesting way of looking at it. I think one of the things that we must prioritize is really having African-owned solutions to the problems we have. And one of the things that I've thought about is to what extent are we using the data that we've generated over the years to develop our own health solutions? Because it's worrying that sometimes we don't even have data about our own problems, our own challenges that we are having. So having a data-driven program management approaches will really go a long way, because having what we call population specific interventions, because different populations have different approaches to their problems. The second thing is, once you have the data in terms of what is really affecting us, then can we just prioritize on having an increased funding towards health? And it's a declaration that governments can have and say, yeah, I know we've talked about WHO capping of what percentage of GDP should go towards health. It has not worked for a long time. But because it's usually driven by someone external. So you go to the World Health Assembly, you have a meeting, then you pose for photos, you say, yeah, we are going to do this, and you come back home, it remains at the airport. We don't even get anything getting back to be discussed in Parliament. But how about if we generated that from bottom up, so to speak? Let me borrow that word, bottom up. That we can have our own declarations at a local level. By the time it's going to WHO for that World Health Assembly, we have already crafted solutions that are domestically generated, including domestic financing towards that, so that you are not going there and saying, my health budget is XX, but I can only afford XY. The deficit, we expect someone to plug in. Okay? So when nothing happens in the process, then the population actually suffers. The very last thing that I want to say, Terian, is health should be everyone's responsibility. It's not for the government. It's my responsibility. It's your responsibility. It's my child's responsibility. So how do we inculcate that such that everyone knows that health is their responsibility and work towards, in our own small ways, towards improving our health from your own household all the way to national government to globally? so that you don't have to look at it now from global coming downwards, but it becomes each one of us responsibility. And yourself, myself, Dr. Oti here, we have a responsibility to ensure that everyone takes health as their personal responsibility. Just the way you are told, security starts with you. So health starts with you as a person.
Health starts with me.
Yes.
Dr. Sam.
Yeah, I think I'll focus on two things. One is on the need to invest in preventive healthcare.
Yeah.
Dr. Githinji of AMREF always says, health is not made in the clinic, it's made at home.
Yeah.
And we need to emphasize, because by the time you get to the hospital, sometimes it's even too late, right? But can we do something at home?
Yeah.
Are there things we can invest in to prevent you from even falling sick? To begin with, and that is much more cost effective. Then we will not even have to spend as much as 15% of our budgets on healthcare because we are investing in preventive healthcare. And what is preventive healthcare? It's vaccines, it's good nutrition, it's water and sanitation. These are things we can and should be investing in. And I think we need to do that. The second thing is technology. I used to host a podcast called MedTech Africa. And I used to speak to people, innovators from across Africa who are developing health tech and digital health innovations. And you'd be absolutely amazed at the brilliant ideas that our young people are coming up with to solve some of the problems that we have. There's this lady that is leading a startup known as Benacare. And what they're doing is they've developed mobile dialysis units. So they have trucks with dialysis machines in them, and they're driving around communities that ordinarily would not access dialysis and providing dialysis with them. We have a group out of Ghana that have developed an AI model that can interpret X-rays. So if you don't have a radiologist, that model can do it at a much more subsidized and affordable rate. So our young people have ideas. They have solutions to some of our local homegrown solutions. But who is investing in them? Again, they are relying on external funders.
Yeah.
Our own governments are not investing in these innovations. So that's a shame. And I think that needs to be prioritized.
And, it goes on to sort of support the claim that, Africans are very smart and we have great policies that are lying on some shelves, across the
collecting dust.
Beautiful policies collecting dust. But we said we're staying positive for this one.
And I can tell you on that, Terian, I did some analysis last year and Ministry of Health has about 217 policies.
Wow.
Okay. Nicely done.
Nicely taking the dust.
Nicely done. But out of those, maybe just a third of them have been implemented. Some of them have never even been discussed with, disseminated, let me use that word, disseminated to the population. I was surprised because I looked at some of them and I'm like, you mean you have this policy in this country about this particular aspect? I thought we are going to develop, but I'm told, this one was supported by World Bank to develop 4 years ago. So how do we translate those policies into an implementation framework and track actually progress? And sometimes we are too fast to review them. You are reviewing what you haven't even disseminated. So you are right in terms of saying we have very good policies as Kenya and most African countries, but the challenge usually comes in disseminating and implementing them.
So, gentlemen, in closing, despite the uncertainty that that we have seen in both the global space and the African health space as well, what gives you hope about Africa's health future and the path to self-reliance? Let's start with you.
So, like I said, young people are being very innovative. They're being very bold. But let's not still discount donor funding.
Yeah,
I work for a donor. And my attitude has always been that donor funding should be catalytic. It's not supposed to solve all your problems, but it's supposed to light a spark that could turn into something that is absolutely amazing. So I think we should not discount donor funding. There are still donors out there who want to do the right thing and who want to do it the right way. And they are willing to partner with governments and private sector in order to achieve positive health outcomes for all. So I remain positive that yes, funding is dwindling, is diminishing, but there are funders out there who want to do the right thing and who are willing to partner with governments and partner with innovators and partner with the private sector to deliver positive health outcomes for all Africans.
All right. Thank you, Dr. Sam. Dr. Barasa?
I'm very optimistic because where we are right now, in a good perspective, is not where we were 20 years ago. Despite the fact that I started hearing this discussion around donor funding cuts that time. 20 years ago, we heard USAID is going to pull out, CD is going to pull out, and all that. USG is going to pull out. Why I'm saying I'm optimistic, because we've seen progression in certain aspects. And when I talk about that, I'm reminded of, in this country, for instance, certain counties that are actually demonstrating that it's possible, okay, to implement certain interventions. There are certain countries in Africa that are demonstrating that it's actually possible. So why I'm optimistic is because what he's mentioned, okay, the demographic dividend of the youths. You find that the youths in Africa are actually rising and saying, we want accountability. And governments, county governments that have been able to listen to them and be able to actually have interventions that are responsive to the needs of the population from an accountability point of view, they seem to be working. So I'm optimistic because I believe in our youth that they may actually help us not just achieve a demographic dividend, but also be able to help us have more accountable systems. And the systems will cut across not just in health. So you may get actually some collateral benefits from all these things that you are seeing. And that's why I'm really, like where I'm working, I'm really looking at having quite a number of youths that are coming within CHAC with very good and innovative ideas. And I support them. We support them to be able to now scale this, and we look for donors that are able to support them. And then we scale up, and hopefully over time, we'll be able to get something out of it. It may take a bit of time though. It may not be instant, it may take a bit of time, but we must be consistent, persistently working towards achieving this. Yeah.
Well, gentlemen, thank you so much for sharing your thoughts on this very critical sector and a very critical issues as well. We've looked at the real life impacts of declining donor funding and what that means for Africa's health systems. We've looked at how government, civil society, philanthropy, and the private sector could also step up in this difficult time for the sector, and actions that need to be taken, both from a local level, national, regional, and globally as well. And of course, how leadership and innovation can be a game changer for Africa's health future. So you have been watching Pulse and Progress, real stories, bold solutions for Africa. So do stay tuned for the next episode, which will be here in a couple of weeks. And we're looking forward to your feedback on what can or should be done to take Africa's health sector forward.